Welcome and thank you again for joining us as we learn together one more concept of physiology. Today we are going to look at the second step of formation of urine, the topic of tubular reabsorption. So let's get started. What is meant by tubular reabsorption? We are going to take the substances that have been filtered, we're going to remove them from the tubules and return them back to the blood. Where is this going to occur? Actually, in every part of the renal tubule. So we're going to look at what's happening at the proximal convoluted tubule, at the loop of Henle, distal convoluted tubule, and the collecting ducts. Remember, we are reabsorbing, we are removing those substances from the tubules back to the peritubular capillaries. Why do we call this reabsorption? Because the first absorption has occurred when we eat and we digest substances and they reach the alimentary tract. We absorb these from the stomach and the small intestine, they go back in the blood. So now from the blood, once they are filtered, we absorb them a second time, and this is where the word reabsorption comes from. Let's look. So substances have been filtered here. They will reach the tubules, the proximal convoluted, loop of Henle, distal convoluted, and the collecting duct. In reabsorption, I am pulling substances back to the blood. I'm pulling substances back to the blood. These blood capillaries surrounding the tubules are my peritubular capillaries. We're going to look at each section and we're going to concentrate on few substances that are being absorbed. Let's start by the proximal convoluted tubule. You will notice that most of the reabsorption will occur in the proximal convoluted tubule. There are going to be so many substances that are reabsorbed here. We're going to start with nutrients. We are going to reabsorb 100% of all the nutrients, all the glucose, all the amino acid, the water-soluble vitamins. All of these are going to be returned to the blood in the proximal convoluted tubule. About 65% of sodium is going to be reabsorbed, and when sodium moves, it's going to affect two other substances here. We know that water follows the salt, so again, around 65% of water is going to be reabsorbed following sodium, and because sodium is positively charged, it's going to pull the chloride that is negatively charged with it to maintain the electrochemical balance. A little of urea is reabsorbed just to keep the chemical gradient. Remember, this is a waste product, and later on it's going to be secreted back into the tubules. Now, we said these substances will be reabsorbed 100%, but let's look at some important concept that we call the transport maximum. Certain substances need the transporter proteins to pull them out of the tubule, the proximal convoluted tubule, back into the blood. I have a limited number of those transporter proteins. If we use them all up, if they are all saturated, any excess of this substance I'm trying to reabsorb will not be reabsorbed and is going to be excreted in urine. A very good example for this point is the transportation of glucose. In order to bring glucose out of the tubule and back into the blood, glucose needs a transporter protein. So this is in a person who has normal blood sugar. The glucose reaching the proximal convoluted tubule is going to have enough transporters to take it out of the tubule into the peritubular capillaries, and no glucose should show in urine. This is a person with hyperglycemia, very high level of blood glucose. I have more glucose exceeding my number of transporters. So we will use all the transporters. They can transport only that much. The excess glucose is going to appear in urine. We call this glycosuria, and this is of course common in the condition of diabetes mellitus. We're going to start talking about reabsorption in the loop of Henle, and before going through this, I want to make sure we understand that we have two types of nephrons, and the capillaries surrounding the nephrons look a little different. So this is what we call the cortical nephron. It is in the outer rim, in the outer cortex of the kidney, and this is surrounded by a weaving network of capillaries, which we call the peritubular capillaries. This is a juxtamedullary nephron. It is closer to the medulla. And when we see here, this is my loop of Henle. It is surrounded by peritubular capillaries that have more or less straight branching around the loop of Henle, and we call these the Vasa Recta, these straight vessels, and we're going to talk about the importance of this as we discuss the reabsorption in the loop of Henle. So we have two limbs of the loop of Henle, the one that goes down and the one that goes up. So this is going to be a descending limb and an ascending limb. One of them is a descending limb and the other is an ascending limb. The permeability is very different, and this is something that will play a very important role here. The descending limb is permeable to water, so water can leave and go to the blood. Water is going to be reabsorbed. It is not permeable to solutes, so no solutes can leave. The ascending limb is different, the exact opposite. It is not permeable to water, yet it is permeable to solutes, sodium, potassium, calcium. These are going to be reabsorbed, and we're going to see that there's a sodium pump that is going to be pushing sodium out of the ascending limb. The result of this difference in permeability is going to make a difference in the osmolarity inside those two parts of the tubule. We will see in the descending limb, as fluid moves down, the osmolarity will increase. As fluid moves up, the osmolarity will decrease. We're looking at the loop. So we're going to look at the difference of permeability. This is the descending loop of Henle. This is permeable to water, so water can move out. This is the ascending limb. It is not permeable to water. Water cannot move out, but sodium chloride can move out. So this is a very important concept. What does this do to the osmolarity of fluid inside the tube? This is the descending limb, and we can see that osmolarity is gradually increasing. As we come here, water cannot go out, and osmolarity is going to start decreasing again. Want to make sure we understand osmolarity very well. So osmolarity means the concentration of solutes. If I have more solutes, this fluid is hyperosmolar. It has higher osmolarity. If I have less solutes, this fluid is hypoosmolar. It has lower osmolarity. And the most important concept here to remember is water will always be pulled towards the solutes. So anytime I have a hyperosmolar fluid, this will pull the water towards it. Because of this difference in osmolarity and the difference in the permeability of those two parts of the tubule, something is going to occur in the loop of Henle. We call this concept countercurrent multiplier. Let's understand this slowly as we go through it. As the fluid moves down into the descending limb, water can move out. As water starts to move out, the osmolarity is going to increase, means I have more salty fluid in here. As the salty fluid reaches the ascending limb, now my sodium pump has more salt. It's going to pump more sodium chloride out. Because I have more sodium chloride, the osmolarity in this area surrounding the tubules, this area, the interstitial fluid, the osmolarity is going to be high. Increasing the osmolarity in this area will now suck more water out. If I take more water out of the descending limb, it becomes even more hyperosmolar. More salt reaching here, we are pumping out more of the sodium. Increasing the osmolarity, we pull out more water. So we are multiplying the effect all the time. And this is very important because this is going to be the only way by which we are going to be reabsorbing those solutes. So from this countercurrent multiplier, let's remember what are the two things that we are achieving. First, we are reabsorbing water and we are reabsorbing sodium chloride, and we are increasing the osmolarity of the interstitial fluid, specifically here in the area of the medulla of the kidney. We're going to look at this because it is very important. We call this the medullary osmotic gradient. Let's look inside my descending limb of the loop and the ascending limb of the loop. As we go up here, remember, water stays in, few solutes are pushed out, and there is a difference in the osmolarity in the interstitial fluid and inside the ascending limb. If I look here, you don't need to memorize numbers, but just to show you there is a gradient, there is a difference. It is always higher in the interstitial fluid, 700, 800, and so forth. It's always higher in the interstitial fluid, and I need to maintain this gradient. It's very important. First, I need to maintain the gradient to continue to reabsorb those substances, and for one more reason we're going to talk about in a minute. So we need to maintain this osmotic gradient. How do we do that? The Vasa Recta come to help us over here. Remember, the Vasa Recta are the very straight blood vessels that surround the loop of Henle, and we have to look at the direction of flow of the fluid and the blood. We're going to look at the descending loop of Henle and the ascending loop of Henle are surrounded by the Vasa Recta, but the direction of flow of the blood in the Vasa Recta is opposite to that of my loop. So we see here blood is moving down where the fluid is moving up. Blood is moving up where the fluid is moving down. So the Vasa Recta will play a role. What are the Vasa Recta doing? They will reabsorb the substances and the water. So here we are going to see that the main function of the Vasa Recta is to produce this countercurrent exchanger. Now you know why we call it the countercurrent, and I will have passive exchange of the solutes and the water between the loop and the blood. We will look at the ascending loop when the solutes are moving out and into the interstitial fluid. Now they will be picked up by my descending Vasa Recta. Over here in the descending limb, when water is sucked out, it is going to enter into the ascending Vasa Recta. And this will maintain the hyperosmolar medium in the interstitial fluid, so we can continue to do this function. So far, we are reabsorbing solutes, and we are maintaining this hyperosmolarity in the interstitial fluid. This exchanger and the multiplier have one more effect, and this effect is going to be on the distal convoluted tubule and the collecting ducts. We're going to look here. The fluid that is reaching the tip of the ascending limb and going to the distal convoluted tubule and the collecting duct is very hypoosmolar, means it is very rich in water. If I leave it as it is without interfering, this volume of water is going to enter into the collecting ducts and be lost in urine. This cannot happen. We need to reclaim this water again. How can we do that? It's going to happen in the collecting duct under the effect of a very important hormone called antidiuretic hormone or vasopressin. What does it do? Antidiuretic hormone is going to put water pores, water channels into the wall of the collecting duct. It will allow water to move. Water is going to move out. What is the force that is going to pull the water out of my collecting ducts? It is this hyperosmolar interstitial fluid that we just mentioned, because this area is very salty. It will suck the water out, and this water goes back to the Vasa Recta. So we reclaim and we reabsorb a lot more of the water into the blood back again. A couple of words on antidiuretic hormone or vasopressin. It is produced in the hypothalamus. It is stored in the posterior pituitary gland. It's called antidiuretic hormone or vasopressin. It leaves the pituitary, goes to the kidney. What does it do in the kidney? It will insert the aquaporins in the collecting ducts. This will increase water reabsorption and return water back to the blood. The word antidiuretic means it is going to inhibit diuresis, and diuresis is water loss in the urine. Let's look under the effect of antidiuretic hormone. This is water coming here, and if we leave this without adding the aquaporins, we are going to lose much of the water in the urine. But right here, under the effect of antidiuretic hormone, aquaporins are inserted. We will suck the water out, and now the urine leaving here is very concentrated. As you can see, it has lots of solutes because we've already reabsorbed most of the water. If we have very little antidiuretic hormone, this is going to be dilute urine, lots of water. We're going to be losing large volume of diluted urine. Situations where antidiuretic hormone is going to be higher, so we can pull out more water back into the blood, are dehydration. We need this water, low blood volume, and low blood pressure. We're going to quickly just summarize the three effects we just mentioned that happen in the loop of Henle. Because of the difference in the permeability of those two sides, we are reabsorbing water from the descending, we are reabsorbing sodium chloride from the ascending. This will create a higher osmolarity in my interstitial fluid. These substances are going to be reabsorbed in the Vasa Recta to maintain this hyperosmolarity. Under the effect of antidiuretic hormone in the distal convoluted tubules, in the collecting ducts, once the aquaporins are inserted, water is going to be sucked in, it's like a sponge, into the interstitial area and back into the blood. The final part of reabsorption, what occurs in the distal convoluted tubules and the collecting duct, the reabsorption of sodium, chloride, and calcium will occur in the distal convoluted tubule. Remember that some more water is going to be reabsorbed because water always follows the sodium. How much is reabsorbed of sodium is regulated by aldosterone, and calcium reabsorption is also regulated by the hormone parathyroid. In the collecting duct, we absorb some more water, bicarbonate, and sodium. And remember, water reabsorption is regulated by antidiuretic hormone. Thank you for joining us once again. And next time we will be discussing the very last step, which is the tubular secretion. Thank you for watching.